schedules to be here with us this evening. I'm Helen Jones Kelly. I'm the Executive Director of the Alcohol, Drug Addiction, and Mental Health Services System for Montgomery County. And I've got a few notes here. The reason I have them is I know that some of you, because I look around the room, some of you have been to some of our listening sessions and stakeholder meetings. So you have an idea already of what we're bringing you into this room to do this evening. And then some of you may have heard that we were having these meetings and have an interest in some way around them. And so I want to just take a few moments to kind of level set the room on where we are and what it is that we are attempting to do this evening. And we'll be doing 2 more of these sessions. And I think the information is on the table this week as we come together as a community to look at what our crisis services need to be for Montgomery County moving forward. That's an important aspect of the reason for being here. And the most important piece of that is hearing from you in terms of your needs and the things in which you find yourselves dealing with on a daily basis with respect to that topic. So welcome. I'm going to highlight just a few pieces of the timeline that we are working with. And then I will introduce our facilitator, and the rest of the meeting will be all yours. So as most of you are probably aware, our service provider for crisis call center, mobile crisis, and crisis receiving center began services here in our community in 2021, November, in fact, of 2021. And then just a month ago, they have exited our community. Over the time that they were here, more than 38,000 services were delivered in Montgomery County, just to give you a scale of the types of services that our community of our size has been able to provide. And that doesn't even really scrape the surface on need in the community. But those were the people that received services during the time frame that they were operating. Last month in May, when we were notified by that provider that they would no longer be providing services in Montgomery County, we brought forward a proposal to continue the services. Our Board of Trustees voted down the recommendation, but offered the idea that we needed to take some time to step back and to hear from the communities within our community that had a perception about the service and be able to offer some feedback on what we needed to do as we move forward. So that is why we're holding these listening sessions, so we can hear from you before we move forward with any planning for the next level of crisis services within Montgomery County. Currently, the only service that we have available now is the call center. We don't have mobile crisis or a crisis receiving center currently. So we're using the state's 988 system to take phone calls from citizens who may be in crisis or may have a loved one in crisis and needing to make a connection immediately. So that's what's offered currently. And fortunately, the provider who exited has left the phone number available to us so that we're able to utilize the service number that people were getting used to using within Montgomery County. Let me tell you a little bit about where we know we're going to be headed after this group of meetings. We're going to be convening a stakeholder group who will help us craft an RFP so that we have the ability to look into this next year for reinstituting those services within our community. And I know some of you are with provider systems and will be interested in how that is going to occur. So the timeline for that is to be able to release that RFP likely in mid-August, if not earlier. And we'll bring a contract or proposals forward so that people can respond to those. And we can get someone under contract at least by January 1 of 2025, if not sooner, as part of this process. We know that the need is very clear, and we want to make sure that we're being responsive to the community with respect to what it is we need, how we need to offer it within our community, and in this case, what are the stakeholders that have impact from the delivery of these services, and what special needs do they have? So we're looking both internally and externally as we begin to build out this process. I think those are the most salient points. In the meantime, we have the state handling our crisis calls, as I mentioned, with 988. We're already beginning to hear a little bit about the uptick that has occurred over the last couple of weeks. So we're trying to meet with them to scramble to get some more capacity on their phone lines to handle Montgomery County. And with that said, we want to talk about next steps. And in doing that, we have asked Scott McGowan. Many of you know Scott. He's certainly very, very engaged in the community and certainly well versed on the topics that we're sure will be discussed this evening. So he spent his entire career supporting the healthcare needs of those not only in our region, but across Ohio, Indiana, and Kentucky. We value your time, Scott, over these next 3 sessions, and we're so grateful you're here this evening. And that's all the bio I'm going to offer on you, so you can talk about you in any way you want to.
Perfect.
Thank you.
Perfect. Is this working? Can you hear me okay? There we go. Thank you very much. I think one of the things too that's important for me to bring up. So I retired from McGowan Brabender in March and spent 35 beautiful years inside that organization. I'm a resident of Dayton, 59, so I spent my entire life here. Married to my best friend. Her name's Lori. We've been married 37 years. Got 2 children. Courtney is married to a guy named Jack. We have 2 grandkids. Those are the grandchildren. We obviously know that maybe we should add them first in this planet. We got a son. His name's Taylor. He's married to a beautiful girl named Megan, and they're expecting their first child. So on the kind of the cusp and the end of my career, what's really important to me is the fact that this region has given me a lot, and personally, I feel like I owe her more in my last third. When I talk about this topic specifically, I went through a large part of my life, the majority of my life, with a really worked sense of self-worth. 16 years ago, I had this perception that your opinion of me meant more than my own opinion of myself. And I got to a point 16 years ago where I did not want to live. And I made an idle threat that if the pain didn't go away, I was gonna make that go away myself. Fortunately, I entered the recovery rooms in this community, and I said, my name's Scott, and my soul is cooked. So I've seen the beauty and redemption inside of recovery, the importance of it inside of this community. I've seen it come alive in my own life. I've also seen the ugliness in regards to what recovery can bring. So my quest for being here today and these next 2 sessions, I don't have a horse in the race. The only thing I care about is building a resource that can be on a quest for the lonely, tired, broken, and afraid in this community. That's what I care about. And it's important. I know it's important for a lot of people in this room. It's important to me. So as we talk about how we bring this to life, one of the things when Tina asked me to do this, I said, I'll do it under one condition. I don't want to know any of the information in regards to what happened or why or who. I don't want any information. I don't want to read about it. I want to come into this environment with a passion for the lonely, tired, broken. I want to lead this conversation in a couple of ways. Number one, at McGowan Brabender, we got in larger settings. We had this acronym called WAIT, which stands for Why Am I Talking? So in a session, as we're bringing some of these things to light, one of the things I'm going to actually consider is what we're sharing. Is it useful? Is it kind? Is it helpful? And maybe even sometimes we could be repeating what the other person said. Does that make sense? Secondarily, when I think about this too, is I'm not interested in who and why. I'm not interested in that. Now there's context. We need to list that, but I'm more interested in what we bring to light as we move forward. And I want to create an environment where people feel like they have the freedom to speak. Recovery and addiction and mental health is a big topic, and it's confusing. Someone once said that ignorance is not the absence of information, it's the perception you have it. There are some people that know a little bit about recovery and mental health, and there's some people that know a lot about it. And all I would say is when people are sharing, I would ask you maybe to listen to seek to understand. I mean, maybe not respond. And so we will also ask that there wouldn't be any crosstalk when people are sharing their opinions or the ideas around how to bring that to life. So a couple of things as you're speaking, if you're speaking in regards to who and why, I might divert you in regards to what and how. Fair? Secondarily, what I might do is when maybe if you're repeating what's already been said, which is okay, I might just note it up here on the wall so we at least get acknowledgement of the problems and the things that we're talking about. Lastly, we have a big room here and we have an hour, and I've always been taught start on time, end on time. So roughly 2 or 3 minutes. If someone is talking too long, I might touch my wrist. And that doesn't mean stop talking. What that means is just kind of wrap it up. Now I say those 3 things, and I'm telling you, all of you in this room mean a lot to me. And for me to tap my wrist is not an easy thing for me to do. It's not. I can say I can do it, but it's not easy for me to do. So let me just say this. I will treat you with the utmost respect and dignity and character in this event. And what I would ask you to do is you treat me in this environment the same way. Fair? Okay. So what we have is we just told me to stop talking. So we had numbers when we came in. If you didn't get a number, and if you would like a number, raise your hand and I'll get you a number. Fair? We also have people on Zoom that will that chat. We'll have people monitoring the chats. So if you have a number, and obviously we're looking for number 1, what we would like them to do is introduce themselves. Fair? Maybe what community they're from, and then their comments.
And before I turn the mic on, what I'll say is these mics, we've been warned, don't naturally coexist. So Scott might walk away from who's speaking. That's certainly not a sign of disrespect. It's protecting all of our ears. So before I turn the mic on, I just wanted to let you know that.
I have a question.
Number 1, I think, is right here. So why we're asking you to introduce yourself and to kind of share your interest in this is because we're capturing comments by very loose categories. Do you work for a provider? Are you in law enforcement? That's a little bit obvious. Are you in the justice system? What exactly? We have board members in the room, which we're certainly grateful for that. So what category? And then we just have plain paper too, so you don't have to say the category, but if you can let us know that would be.
Hi, everyone. I have number 1 because I thought this started at 5. So I was here at 4:45, so I was really early. My name is Lauren Mercer. I'm currently a grad student at OSU. I formerly worked at Artemis Center for 3.5 years. I am now at Dayton Children's Hospital, and I am a former mobile health advocate. So I went out on the health calls, and I promise I come here with no mouths. Our jobs, FYI, were picked up by another grant. So, and I can talk about that at a later time, but we'll be working at Dayton Children's. So my question actually has to do with children. My question is, how would you describe how the city currently addresses youth suicide? And how would you like to see the problem addressed? Or would you like to see a policy reformation?
I don't have the answer to that question.
I apologize. So tonight, what we're asking for is input on the topic of what we need to do for our crisis services system so that we can plan to meet the needs of the community versus answering specific questions. However, there is a sheet, and any questions that you may have, we can certainly apply to that sheet and can be responsive to everyone in the room on particular questions. Unless there's a burning question that comes up that absolutely demands a response of some sort.
Can you maybe repeat that for our Zoom audience, Scott? And just briefly. That this is more of a gathering input, not a Q&A session.
Correct. So what we're really looking for is we're gonna build a model for what looks like, what does an RFP look like? What would those solutions look like and how would they operate, how would they work? I think for the board and up here, I think the big question in the RFP or that process would be, is adolescent mental health and suicide, is that important in the community? I think the answer is yes. Fair? Yeah. 2.
Hi, my name is Steve Reffner, and I am a retired therapist. I have 22 years as a school-based mental health therapist. And looking at my resume, I've got about 40 years of crisis experience here in Montgomery County. I first started out volunteering at the suicide prevention. I worked at Eastway Crisis. And then I spent 22 years at crisis care. And I guess, I don't know if this is, I guess my question is, my statement is this: I think crisis care did a very good job in those 22 years. And I personally would like to see something like crisis care come back, if not even crisis care, because they had 22 years of experience. I worked there from the first day that they opened, and I was the person who actually closed crisis care the night that RI started. I can tell you right now that we have tens of thousands of success stories and positive interactions. And I would like to suggest that crisis care be seen as the model of what should be built on for this new approach for crisis in Montgomery County. And I will say that Montgomery County is a busy crisis place. And definitely you need to include mobiles, walk-ins, pre-screens, all that kind of stuff. But I guess I'm still kind of confused as to why crisis care is not in business, but I still think that crisis care is a good option for this community. So that's what I'd like to say.
Great, thank you.
My name's Leanne Fulford. I am a volunteer in the community and I work with the Montgomery County Prevention Coalition as well as several other organizations. And I too am involved with youth suicide and concern. I'm also an assist instructor, which is applied suicide intervention skills training. And a lot of people who come to our instructions are crisis line workers. And the question that has come up recently in classes that I've taught in the last 3 weeks is, why did we not go with the 988 to begin with? It seems like there is an overwhelm, like you were saying, or I don't know where she is. Nancy was saying, or Helen was saying that there is an overload right now with the crisis call line, I believe. Is that what she was meaning? Okay, yeah. And I was talking to these people, and that's wearing on their mental health. So I guess my question is why. I think we do need to have a local facility, but I'm not sure we need to have a separate number. 988 is like 911. It just seems easier for people to get. So I'll be quiet for you, Tucker.
Yeah, no, because I think one of the things too, we had talked about specifically, and it's on this board here. So it was 988 and a mobile response. That's 2 providers, fair? And then you had crisis center and mobile response up on here, fair? And I think you also alluded to the same thing, the impact. I think the difference is you're talking about a crisis call center, and I think specifically you're talking about 988, fair?
I think so. I really don't, the thing that happened, I'm sorry, now I'm going over. So the thing that happened was, as I understand it, the calls now, we own the number. Correct. Okay. And then the numbers are being transferred to 988. which it goes to another facility. Okay, and those people are being inundated with phone calls. I think now it's a little bit clearer. Before, people thought they were calling a local facility, and there was a lot of stress and concern from the people who were calling when they realized it wasn't the crisis care center right here in Dayton. And they were concerned when they found out it was outside.
Fair.
Okay.
Yeah, no, that's fair. Fair.
Number 5.
We may tag team this a little bit. My name's Chris Finkelman. I'm with TCM Behavioral Health Services, and we're a provider in Montgomery County, Greene County, several other counties. We're also one of the 988 centers, along with Sojourner, which is the other one that is the primary 988 for Montgomery County. We get a lot of overflow. The one thing I would say about 988, it's an imperfect system, and the community members wouldn't necessarily get routed to one of us. There's still, it's early in it. It's not a guarantee that if 988 was the local number, that Vandalia PD would necessarily get one of us to help initiate it. It could get routed to another backup center in Talbot House down in Cincinnati. It could be another one in the state. It could even go outside of the state. So I think it's important to say that as a part of the discussion, that using 988 is not necessarily the sole solution for that, as that still continues to roll out. And I would say 911 took about 10 years. I think 988 is ahead of that game, and I think it'll move along quicker. But I do think that having a mobile response is key. I think there's a couple of departments in Montgomery County that a model that I believe is a good one is having a worker embedded with law enforcement or the fire EMS. That is having a lot of success in other areas of the state. It seems to be a model that people are gravitating towards. Those are the first responders, are often the ones who are going to be the first responders for these calls, and it's not necessarily coming through a local crisis line. So I believe that's a model that can be very effective, and I know Montgomery County Adams Court has piloted that, I believe, in Vandalia, I believe in Kettering. I'm not sure if there's another one. We've interacted with them well, and I think it serves both very well in bridging those gaps and improving the process. So.
Thank you. And I don't know the answer to this question, but you know, as I think about 988 in regards to the crisis center and the call center, is it a possibility in the routing of that phone call that the first phone call it looks locally or it looks farther? Is that fair? Or does it just go?
Yes, it yeah, it's a good question.
Well, if I call 988, look locally for the resources for the person on the phone, and then it starts to stretch beyond that. If that unit's not available, it starts to stretch on the state.
It's based on your phone number so the first 6 numbers associated with your phone number. So my number, when I call it, goes to TCN. I live in Montgomery County. I live down in Springboro. My wife's number is a Charlotte, North Carolina number. So if she were to call, it would route her to that. And that's one of the challenges, not geolocated, but the 2 primary centers, and even Talbot House is getting some of those, and it doesn't come through either one of us first.
Yes. Is that area code based? Is that how you're saying?
Area code and then the first 3 numbers after.
Yeah, fair. Yeah, thank you for that feedback.
Perfect. My question was 7. that we might.
Hi, my name is Curleen Berry, and I guess I have probably a different perspective. I'm on the end of an end user. I have a loved one who has a mental health disorder. And through this experience, I've had some experience with each one of you in different capacities. As a family, it's very limited in terms of when you reach out to different organizations, you're already in some type of crisis. You're trying to find a resolve. And so each time like I call crisis center, I've had mobile crisis, I've had law enforcement, all in an effort, I've called Adamus. Someone give me direction, someone give me a roadmap. Each situation is different. The person, in this case, the loved one who needs assistance has a mental health disorder. What tells him he's fine. Well, he's not fine. If I need a heart surgery and you saw something wrong with my heart, it's visual. You could tell that. His brain is the organ that's not functioning. So it's not telling him he's okay. But yet he's slowly deteriorating. And because he's an adult, I have limited abilities to take any action. So I'm reaching out to the providers. So when we talk about crisis, we're talking about mobile crisis center, mobile crisis. That means I need help right now. A week from now, 2 weeks from now, he might be dead. I don't know. He may be, I don't know what activity he's gonna have, but I need help as a resource to help him. And then as a guide, someone give families a guide. And so often you hear from providers that, well, you're a supportive family member, so often we don't have families engaged because there's all types of mental health disorders, but some disorders are worse than others. And that person needs help from outside resources. But I feel as if you're just constantly running up against barriers, no matter what you do. And you're very limited, and there's no direction. It's trial and error. And it shouldn't be that way. It doesn't have to be. And I feel like everything gets lumped in together when these people are not suffering the same.
Is there a difference between advocacy and crisis?
Yes. Yes.
Gotcha. So, and I'm sorry we're going through it, but I think what you're saying is, look, I'm left here alone and then you're a resource. And I think what I'm hearing is there's crisis inside of that, but also advocacy.
So through this whole endeavor, I'm here to also get information and just make that blanket statement that these families need the resources, but we also need a roadmap as to what's available for us to use in our limited capacities.
Fair.
Very good. Thank you for sharing.
Actually, can I give her a round of applause?
Yes, thank you.
And thank you for sharing that. I think that should be a big letters.
Thank you.
Because they're the resource. I mean, you're the professionals. You do this every day. I am very limited, other than I love my family member. And so if you go to the doctor, you get the information, they treat, and you follow or not, etc. But when this person has a type of disorder where they cannot they're not gonna call 988. That's the last thing they're gonna do. I'm gonna try to call 988 to be preventive. I'm trying to be proactive. I feel like the system in every avenue doesn't allow you to be proactive. So that's probably my biggest challenge.
Thank you. Thank you so much. Number 9.
I've got it.
Okay. You want-
Yeah.
You had number, sorry.
All right.
Number 8, right? I apologize.
Good evening, everyone. I'm Kurt Aldhouse. I'm the police chief in Vandalia. and past president of the Montgomery County Association of Chiefs of Police. First of all, I want to say thank you for having these meetings. I appreciate it. Allows us to give some input. This evening, one thing I would like to focus on is the importance of the Mobile Crisis Co-Responder Program. Several years ago, I believe it was 2018, 2019, Adamus had approached us as one of the agencies to pilot the co-responder program. And we have now participated in that coming up on 6 years with our partners in Butler Township. And with that pilot program that began in 2020 and into 2021, we found some great benefits to the residents and the citizens of Vandalia and Butler Township who were experiencing a crisis, a social issue, perhaps homelessness and addiction, where we had a co-responder in a patrol car with officers who were responding to those calls for service when needed. And unfortunately, some of that funding went away in 21, but we have felt so strongly about that with the support of our council and the township trustees. And I'm speaking on behalf of my colleague, Chief John Porter from Butler Township, who couldn't be here tonight, that this program, we have went ahead and funded that partially through our own communities and through some outside other sources. So one of the things I would advocate for as we move forward is if the Mobile Crisis Responder Program can continue to partner with law enforcement, because many times our police officers, our deputies are the first ones on the scene when there is a crisis. And I appreciate what Atlas has done with the crisis intervention training. We have our officers that go through that 40-hour course that gives them a lot of insight to skills that they need to respond to mental health crisis. But having that responder there in our community who responds with officers can help provide intervention services, can make referrals, can make recommendations. And not only at that time, but the co-responder we've had has also done follow-ups with these individuals. Are you seeing your provider? Are you going to your appointments? Are you taking your medication? Do you need more support? If there's not the family support like this lady mentioned, that co-responder is providing that support to make sure that they're getting their needs met. So our police officers, I know, are passionate about this. We handle hundreds of calls every day in Montgomery County that police see. And we want to get them to help. They don't need to be arrested and go to the jail. They don't need to end up every time in the emergency room. And a lot of times police officers sometimes get frustrated when they don't know the resources. But having that co-responder there with us and being able to offer the services and then go back, on their own. There's times they go out on their own to follow up with these or make the phone calls, really has been a great resource for us. So one of the things I would ask to consider is that partnership with law enforcement for our co-responder programs. And I'll wrap up with this. And while I realize our international is not here, one of the things we lacked is if they did have a mobile crisis responder come to our community, we never knew about it. We never got notification. So if there are some independent co-responder programs that are out there and that happens in the future, if we could have them share that information. We're not looking for diagnosis. We're not looking for medical history. Just, hey, we visited this resident on a crisis, just so you're aware. That way we're not duplicating services or anything like that. So thank you.
Thank you. Yeah,
Thank you, Chief.
important to say.
Judge,
No question about it.
Thank you. I'm David Brannon, the Montgomery County probate judge, and my relationship with all of you, we run civil commitments. There's probably 200 on our docket. Those are people that have been committed, pink slipped, if you will, and there's a couple of ways to get them to us. I run a bi-monthly stakeholders group, which is basically justice partners. I don't know how many people are there bi-monthly, but I've been in this room, court administrator from juvenile court, a couple of the Chiefs Association, city council, some reps, others I'm missing, Adamus, the jail. I would just make the observation that we're missing data. Like that's the one piece we're starting to collect probate court, and it is shocking that we don't know how many people have been pink slipped per month, which we're now tracking. We don't know how many of those get converted to probate, which we're now tracking. We're all kind of flying blind. We're listening to needs and wants, but why don't we start with the data and start there? I mean, how many dropped off at the hospital? I bet nobody in this room can answer that question. And it's a lot, hundreds. And very few of those make it to probate. That's just one of many, many thoughts that I have, but let's collect some data.
Thank you. Yep.
Number 10.
Was it the mobile crisis?
It has really served a purpose and it's been proactive. In a lot of,
Were you a
ways.
provider? Or-
Yes.
Okay,
Mhm.
perfect.
Yeah.
So we'll just go ahead and start up.
Yeah.
Great.
I don't have anything to add. It's very comprehensive, so.
Thank you. Thank you for being here. Number 11.
That's new. Hi, everybody. So some of you in this room I've talked with in the past. My name is Michelle Campbell, and I don't have a title. I don't believe in titles. So even if I had one, I wouldn't tell you guys. One thing I would say that I am someone who cares deeply about the mental illness that is going on across the USA, especially within Montgomery County. Some of you all know that I am a mother of a mentally ill son, and he has one of the severe mental illness, which is called schizophrenia. I have been fighting since 2021 to understand the lack of resources that is available for the members here in Montgomery County. I have been uneducated in what I will call the purpose of the probate court and what power that they may have in making sure that the community mental illness people and their families are receiving proper services. So since we are here to give ideas of what we think we want in Montgomery County, I have a few of them. Number one, my first request is that I would like to see a Pacific hospital or a care center with beds for mental illness, not the jail, okay? That's not gonna work. I don't wanna see our mentally ill people in jail not receiving care. I have a son that was in jail for 13 months and had received no treatment for his mental illness because we allowed them to say no. And they don't have the capacity to make a just or rash decision. So the problem that we're having is because we have created that. It is our responsibility as a citizen of Ohio and Montgomery County to take care of our mentally ill citizens. No more should we be sweeping this under the rug. Judge Brandon, I respect you very, very much, but I do disagree. The numbers are there. And when we get those numbers, and while we are waiting on those numbers, what happens to our family members, our community, and our loved ones when we are unsafe because we have people out there that are refusing to take their medicine? So my question to you, sir, when you decide to get all of these numbers, I would like to see what your plan is to implement a solution. Yes, my son has been pink slipped many times. And he goes to the hospital. The most he's ever stayed is 10 days. That's if the probate court can demand that he stay a little bit longer because he has to have a hearing. And of course, they can ask to be released and they would let them go. Okay, so what I would like to see is a mobile crisis care coming to my home. When I call, whether it be 988 or the old crisis care number, I want a car with a mentally trained police officer and a mobile crisis worker at my door. And I'm not talking about 30 minutes. I'm talking about within 0 to 25 minutes. Period.
After that, I say, why are we sending all of our mentally ill people to the emergency room? Don't we have enough psychiatrists and trained professionals that we can have our own facility that we can transport these people to? And they can begin getting the treatment that they need. And if they need 30 days of treatment to be stable or 60 days to be stable, like my son needed, they can stay right there because there's a bed, there's food, there's counseling. That's what I like to see. Oh, yes, and we want to make sure that they don't have diabetes because a lot of the medicine makes them obese. And we all know that they are at risk for heart disease, diabetes, and high blood pressure. So we want to endure, we want to make sure that they have a healthy life. We have a lot of things out there that can help them, like Ozempic, Wegovy. We need to do research to find out what that can do to help our obese, mentally ill people, because just like you, they have self-esteem. They don't want to walk around all fat and people looking at them and making comments about them. They want to feel good about themselves. So while we are treating them mentally, let's treat them physically. Let's give them counseling, and let's bring the families in, the mothers, the siblings, the sisters, the brothers, those who want to participate. Let's bring them in for counseling too. Let's build a community of love and caring. I love Judge Brandon. I love what this guy said. What you said, sir, was powerful. We have an agency that we can collaborate right now. Let's bring that to the board. Let's find out the things that they're doing that is working and implement that and build that here in Montgomery County. They part of Montgomery County now. That tell you some of them, they're not Butler County, they Butler Township and Vandalia, which is part of Montgomery County. So let's begin the work. Let's stop talking about numbers and let's put that information on the board. Let's draw a flow chart. This is point A. We're going to start here. And when you get here, we're going to draw an arrow and we're going to send our people who are able to go to point B. What is point B going to look like? That's what we need to decide right now today or in the future. Then we go to point C, point D. My son used to be so stable, he had a job. He graduated from HVAC school, but he can't get no support. So a lot of mentally ill people are capable of being valuable members of society, not just felons, not just criminals. They could be taxpayers. Thank you. I'm sorry. I love you guys. Thank you for listening to me. Line number 12.
Hey, it's me again. I'm gonna go fast. When I first spoke, I spoke to you as a college student, you could probably tell. Now I'm just gonna talk to you as a human being. I'm a little emotional. Your story made me really emotional. No, we should be emotional. We should be emotional. When you said that 38,000 people were helped by mobile crisis and that I was a part of that, I felt really proud. So it's good to know we made a difference. I'm married to a veteran who has PTSD. And one morning, he called me and he said he was going to jump from the top of his building. And what we needed wasn't there. He could call 988, but I've been doing mental health work for years. So I talked to him off the roof, into the car, and into our backyard where he picked cherry tomatoes with me. While I de-escalated him And we spent all day on the phone looking for psychiatrists and psychologists and therapy. But nothing was open. And we had to wait. We had to wait. There was nothing for the in-between for a veteran about to take his own life. We couldn't get the help we needed when we needed it, and thank God for the work that I've done. I also used to work at Kettering Behavioral Hospital. I was a mental health tech. The job didn't pay much, but what I did was when you woke up in the ICU from overdosing on your trazodone, I was holding your hand. I held the hands of men who had slashed their wrists to ribbons. I have held the hands of women who tried to poison themselves by lighting the things you would put on top charcoal briquettes, and she crawled out of the bathroom just in time. And it is because of those skills that I was able to get my husband home to me. He eventually did get help, but not when he needed it. So thank you. Thank you.
Thanks for sharing. It goes back to what you were talking about, it's having professionals that understand it. I talked to a lot of parents, and I've only been involved in recovery for 16 years. I've watched death, I've watched redemption. And a lot of times, specifically when we're talking about mental health or even addiction, some people will say, I don't understand. Like sometimes, sadly, the response is, maybe sometimes be grateful you don't, because if you did, you'd be just like them. So it is complicated, and it is heartbreaking, and it is complicated, and it's difficult. I think are we on 12, Tina?
Yeah, I think we're on 13, but it's back there on the table. Does somebody have a number who's not spoken? We have several people online who would like to say something, but is there anybody in the room who has a number who's not spoken? Okay, how do you want to do this? Do you want me to read you
That'd be
the
great.
comments, or do you want to read the comments out loud? We do have someone who specifically wants to make a comment. Do you want to just kind of read them?
Is it right
Oh,
here?
yeah, you can do it right there. Yeah,
Right here.
sorry.
Janet, was that Michaelis RN, emergency nurse. I also attended some workshops in the tech space looking at the conversion to 988 from a national perspective. I would like to see a comprehensive mapping of all organizations and institutions in the county that are currently in place, providing some faceted care in this space, as well as journey maps of how people enter and move through those services right now. We do not have a thorough understanding of what's here and how various phone entry points do or don't work. Well said, well put. What's that?
Hello, everybody. My name is Kimberly. I do work with the Adamus Board. Janet, to answer your question, statement, we will be doing sequential intercept mapping August 1st and August 2nd to do exactly what you're talking about. So thank you for sharing that. And we absolutely agree. So once we have that, we'll be able to prioritize the focus areas for our community.
See. I put my glasses away. A lot of feedback, loved one dealing with mental health, touch home for me. Okay. Sister Jaren Thompson. Killed by police department in a mental health crisis in 2017. I advocate for non-police response to respond to those in crisis. Would like to prevent this from happening. My brother is an example, co-responder, model that failed. He called for help and was beaten to death by several officers, an ambulance, and so forth. So again, a mobile response unit of folks there. Let's see what I can do here. Bill Plummer, I have a statement to make over Zoom. What do you want to do about the Tina?
You can unmute.
So how do I?
He should be able to.
Oh, here we go.
He should be able to.
There you go, Phil. Go
Hey
ahead.
Scott, how you doing tonight, Scott? Can you hear me?
Yeah, sure can.
Hey Scott, thank you for taking your time out of your busy life and leading this important endeavor we're bringing on here. I want to make a statement on behalf of Adam of suspending the $1 million to the jail. Now that we lost our eye, the jail is going to be the #1 place to take everybody once again. When I was there, we had 40% of our population had mental health illnesses. So we need to fund the jail. They need more funding. They don't need to be cut $1 million. That's malfeasance. So I wish the board would relook at that. A couple questions. Tina, how many officers are CIT trained nowadays? And are our jail officers CIT trained? I mean, if that's going to be the drop point for people with mental illness, suffering from mental illness, we need to make sure our officers are properly trained. Going back to data, like the judge said, we need data in this community. We need to know what our universe is to make sure we have the appropriate resources in our community to handle this. I mean, there's plenty of money in the state of Ohio that we keep sending back for these problems, but we need to figure out what our problems are. Same with our substance abuse problems. We need to know what our universe is. That way, so we need to pick our games up here. But my problem right now is the cutting of the jail funding or holding it. I mean, that's irresponsible. It needs turned on and probably doubled under the current circumstances. That's all I have. Thanks, Scott.
Yeah, thanks, Phil. Let's see.
Okay,
Is that it there?
I think we've exhausted the chat. Yes, ma'am.
Make a comment.
Yes, ma'am, of course. I need your mic just so the Zoom audience can hear you.
My name is LaDonna Ross. I'm an advanced practice nurse. I've been a psychiatric nurse for 44 years. I don't know that maybe this gentleman and this lady might be as old as I am, that know what has happened to the mental health in this country and in this community. Years ago, when I first started, if somebody was mentally ill, you called the police, you got them probated, they took them to the hospital, St. Elizabeth, Miami Valley, or Kettering. I don't know what these hospitals are doing now because I'm no longer working. But some of your problems is because of insurances. The insurances want the people out of the hospital before they're ready. When I worked on the floor, people could stay 90 days. They were treated. The family came in, people received therapy, they received medication. They have the Valley and the Kettering, I know both have home care psychiatric services. We need to use those. We need the hospitals to start listening to us. I mean, people go into the emergency rooms now, and I know the police is getting frustrated with this. They go and pick somebody up who says they're suicidal. They go to the Valley or Kettering, and the hospital says, "Are you suicidal?" Of course, the patient says no. Okay? They don't want to be probated in or whatever. Or the hospital asks them, "Do you have a plan?" Now you have to have not only a plan, but you better have a knife or a gun with you, right? They're not doing it the old ways, the ways that we did it. This is why you have an increase, along with the drug system problems now. You don't have the system we used to have that took care of people. And one of the reasons is because of the insurance and the money. You know, you really need the old systems back. And this young lady here shaking her head, yes. You need to ask as old folks how you do mental health and how you support people. And, you know, don't always believe these people. Like your husband, he might go to the hospital because the VA is not too great either.
I didn't bring him to the hospital because he didn't have a suicide attempt and I knew he wouldn't go inpatient.
But see, before, they used to hook these people up with outpatient at crisis care, at the hospitals, at home care. You need the old system back to really take care of folks. And you need insurances to back off. Because you know, these people with the insurances, I'm not degrading anybody, but they might just be a secretary. They don't know squat about mental health. You need people that know about mental health. You need people that care. And you know, this is what you need. You need all these bases. You need something like crisis care. The mobile system is great. We never had that long ago, but it's doing great, it sounds. And we need to increase that. We need to increase crisis care. We need the hospitals. I've seen people I'll tell you a story that happened a while ago, and I won't tell you what hospital did it. But there was a lady who was in her 60s. Her husband had a very good company that he built. She was severely depressed because he had a heart condition. He could no longer work. And so she became depressed. They owed money. And the insurance said this lady needed to get out. And they kicked her out, and she was still depressed. I don't know what happened to her otherwise. But you need the old system back. You need to get the money out of all of this. You need people to care.
That's right.
And this is what you need. I mean, you just have these little, 10 days maybe here, 2 days there. You don't have really treatment.
I think, I think we read this morning too. I think the addition, obviously of the hospital. Now that's what.
I think the hospitals need to be here too, to hear this and be part of this.
Right.
And the courts and the police, everybody, you need a whole care.
And the jails, I mean,
Yeah,
the training
this
needs to
needs to
be, I was in the mental health system as a provider, as program supervisor for 45 years. And I'm retired, and I've done all of these things. I have been in people's homes. I have been the one you connected with. I have been the one who had to contact crisis care. I've been the one who met the cops out at somebody's house to help calm things down. I've been there. Done it all. And I've been there when crisis care started. I'm that old. And throughout the full progression of things. I was at Eastway when Eastway had its own crisis center and had its own crisis unit. And, all those things on a small scale. We developed relationships, we had the connections with the community, we provided the personal kind of connection with people. You got to know your provider as a parent, as a kid, a person who has to be concerned. I'm now also the relative of people who have mental illness and drug addiction. So I know I'm kind of like the family advocate, for all of that. So all of this, I think there's nothing wrong with gathering statistics. There's nothing wrong with all of the things that have been recommended here, but it's got to be on a local level. There's got to be that connection. There are resources here that have been that are available that you have to tap into. There are people who have history and have knowledge that can provide some of that context to things. That's all I can say. I'm just.
Well, we need more psychiatrists.
Oh, psychiatrists, providers.
Doesn't matter. When I started working, one hospital had 20 psychiatrists. Now, whether they have one or two or something.
And agencies can't keep case managers, agencies can't keep counselors, because the system is just broken.
We had someone who skipped her turn and I promised I'd come back to her. That's what she chose.
Yeah, I'm Sue Hannon from NAMI, the National Alliance on Mental Illness. So I have to echo what some of the family members said, is that any crisis services need a great close connection with all those community resources, because behind that person that is in crisis is a family member. And they may not know what's out there, what to do. So besides serving the person that's in crisis and giving them resources, we need to have the ability to really get people that support that person, the support they need. So, yeah.
I heard a lot about the crisis unit. So I've heard a lot about that, and I think we've noted that. One thing I haven't heard, and I'm just gonna ask a question around what can be new, better, or different, is a crisis center. So like a crisis center where, in other words, do what? Got it. Okay, then we'll mark that down. Versus just using the emergency room, or just using, obviously, a police department for that.
We have a gentleman here.
Well, I was looking at the SIM that was done back in 2019. Priorities had not changed So pull out the one from 2019. Sure, it needs updated. But it starts off with number one, crisis drop off and stabilization. Number two is assertive community treatment. Number three is housing. Four is residential treatment. Five is information flow of case complainant and jail intake. These have not changed. We're going back in time. I know Phil Plummer said this before. We keep reading everything that we all basically comes down to funding. But then the bottom line is in law enforcement, I'm the current President of Chiefs Association, and Kurt handed the reins over to me this year. And one thing that we've worked on together with Judge Brandon for the last year, one of the hangups that we have in law enforcement is the pink slip process is absolutely broken. That is a ability that we have on the street. Police officers come across some of the more crisis type situations every day. And then we count on local emergency rooms to take these folks and review their case and hopefully give them some treatment. And we find that they're back in our communities in less than 4 hours with regularity, to the point we're asking the hospitals, if we're doing something wrong, please let us know. 6% make it to the judge. So when we talk about the cases that don't make it to the court, he can't do a thing about it if they don't make it to him. So there's a breakdown. There's a breakdown from the hospital to him. So you can't blame the judge because he doesn't get the case, there's nothing to do about it. Secondly, we talk about family members. Oh, I get it. I had a schizophrenic bipolar brother that killed himself less than 10 years ago. I get it. We talk about these applications to buy a gun. It's on the honor system. HIPAA's an issue. Everything's a secret. These gun dealers can't find some of this stuff. So we talk about problems and start to peel back the fruit there. The bottom line is when we don't have the information, they will give us the information. We write on these forms what the person told us. Now we're even having to put an asterisk on the form that says this behavior was described as film no body camera footage. Body cameras are wonderful. You know, it exposes a lot of great things. But one of the things it does expose when somebody says, I'm going to do this, I'm going to kill myself, I have a gun, I have a plan, I'm going to kill my family. All these major admissions. We put these statements on there. 2 hours back in the community, because I heard a term in one of our meetings that was interesting. They said, well, that's that person's baseline. Okay, that's a new term. I hadn't heard that before. Nobody ever explained that with my brother. His baseline was all over the place. He didn't have a baseline. But baseline is a term they're using. Well, we feel they're within the baseline. We release them. Interesting. So then the person we just dealt with on the street, where their neighbors and their family are saying, please help this guy. We take the guns, we take the weapons, we put them in our property rooms. And then when they're let out that quickly, then we have another conundrum. How then do we keep these weapons from these people that are released quickly? They don't even make it to the earth. So a lot of these things that we're dealing with, probate court, I'm sorry. When we talk about these things, it's a big circle. I understand everybody's here and we're trying to find a solution. But the problem is we thought with RI International that we had this oasis in the sand that was going to develop at time, that we would have another facility other than hospitals. All the officers hear the same thing. I see Centerville over there, Big Days here. Every hospital, what's the first thing they tell us? We don't have the room. We don't have the facilities. We hear that every day. Well, we take them where we can. The jail's not the place for them. We know that. But they are trying, because ultimately that's the last spot that they're going to end up. So we're trying to help the sheriff and not take them to jail. But then we take them to the facilities that are available. A couple hours, they're back out on the street, nowhere to go. The veterans, we hear this with the veterans. Veterans have come up with a new plan that we can take them down to the VA. So people are trying, but again, there's limited resources.
Yeah.
Haven Behavioral Hospital is an inpatient mental health hospital in Dayton. They have 59 beds and walk-in phone assessments for those in crisis.
Can you take, can you have a comment? Is that Is that? Facilities.
So that's available, you're saying that's available.
They will. So you need a place that maybe emergency, then you need a place for people at their baseline. So that they can stay there indefinitely, maybe 90 days, like we used to. And they can be treated, and the family can learn, and the patient can learn, a holistic place. That's what I was going to say.
My name's Dawn Schwartz and I'm on the Community Overdose Action Team. To piggyback on what Chief Jerome was talking about, we must have a crisis receiving center.
Yes.
Because we see so much revolving door with the hospitals. For whatever reason, they don't keep them, the ability, at least for the short time that it was open, to have our law enforcement and other people to take people to that receiving center for that triage. So they can determine what further actions need to be taken, whether it's a pink slip or whether it's getting them immediately connected to treatment is important. So yes, I'm for the 988. Yes, I'm definitely for the crisis mobilization unit, but we have to have a crisis center to help take the onus off of our EDs, which are struggling to do anything with, and with our jail, who is doing a great job with our mental health. But like Chief Jerome said, it comes down to money. And if the jail is not equipped to have the top psychiatrists in the world.
Right.
We also, we agree that we all agree that we need more psychiatrists. You can't make people go into a field. I speak from experience. I work with the addicted population and there are very few addiction specialists. But we have to figure out with the resources that we do have or that we can put in, we have to figure out a solution because we need to reopen it. That's this receiving center.
I could get in big trouble for saying this, but I'm gonna say it out loud, because I came from the insurance industry, but I've always had that philosophy that insurance companies where a good idea is gonna die. When you think about the impact, whether that be Medicare, Medicaid, or even the commercial sector, if that makes sense. Because some of you have even said, you look at the specialists, you look at, if we're gonna solve a problem, we have to create an industry that's attractive for people to enter into. The people that work in this field, I'm talking about psychiatrists, psychologists, and people that work in the addiction and mental health field. They don't get in this field to make a lot of money. Fair?
Right.
No.
Right.
And the only way to do that is you need to lift up the reimbursement schedules to make this more attractive for folks like that. And that is, and there's only one entity that can do that. And 85% of every healthcare dollar is paid for by employers. So employers want this, they want this solved. They want mental health eradicated inside their environment. They also want it inside of the community, and they deeply care about it. And so what I want to make sure that we did note on here is the impact of the healthcare systems. As we talk about a crisis center. But also, in my own exploration, we'll spend $1.9 billion in the state of Ohio. And there's no question that we could spend that money more effectively. Fair?
Yes.
Could. And I think what folks are really interested in this community is how do we create something that's new, better, and different to serve the lonely, tired, broken, and afraid, those people. How do we do that in a compelling day? Other questions or other feedback? Go on first.
My name is Joel Zugner. I work with the Dayton Municipal Courts for the last 28 years. Last 27 and a half, I was a probation officer, and now I'm in compliance and operations side administration. I also sit on the board of trustees of Nova Behavioral Health. I don't want to bash RI, but I will tell you that one of the things that I know that has been an experience is when RI would call Nova Behavioral, they would say, do you have a bed? Well, that's not enough enough of a question. You need to tell these agencies, what kind of bed do you need? Do you need a female dual diagnosis bed? Do you need a male dual diagnosis bed? Do you need a male just mental health? Because all they wanted to know was, do you want a bed? And that's, so whatever agency takes over this crisis intervention center, and I desperately believe we need one, when they're talking to when they're trying to basically move the client to to a new agency for treatment, they need to know what questions to ask and ask them the correct way, because we're just not communicating effectively, because you're trying to get the right client to the right agency and into the right bed. And, and that's exceptionally important. So that's all I would have to say about that.
Thank you.
Yeah. Well, it kind of goes back to what you're saying, is if we understand the input we're looking for, we can then identify and measure the output that's expected. So if the organization is just looking for a vet, right, without any input, then the outcome is going to be what? Well, correct, 100%. So that input data that's coming, that is really important. We're going to start measuring output in what we're trying to create here. Other questions?
This is more of a suggestion, and that is, I'm a car surveyor, so I know that there are crisis receiving centers out there across the United States. I know that, in all honesty, if you're familiar with CARF, if I was the surveyor at your organization and you had a crisis receiving unit, I would consider that a huge strength in my report about your agency at the end of the survey. So my question is, or my suggestion is that maybe the Adamus board needs to start figuring out where these crisis receiving centers are and start sending people there to observe what they're doing right, and what they're doing wrong. And bring that information back to this group of people. I mean, they're out there already, so we all agree we need it. So, find out where they're at, find out what they're doing, and actually go see these places, see what they look like. And my guess is that they will talk to you, because they're probably going to want to show off their program.
Yeah.
So
Good feedback. Point.
Yeah, Mr. Nips.
My name is Wayne Davis. I'm the city manager of the city of Centerville. So I'm going to do a little straw poll, so you guys are going to play along with me here. How many of you have been touched personally or professionally by somebody with a mental health issue? It should be about 100%. How many of you, this is the second question I'm going to ask, so it'll be the last question. How many of you consider yourself subject matter experts on the full gamut of mental health? Well, then these would be our leaders to actually, because really what we need to do is not function as an island, because this problem is not going away. It hasn't gone away. It's been with us for our entire history, and it will be here after many of us are long gone. But we've got to figure out a way. The chief talked about, Chief Jerome talked about funding being an issue. Well, funding is an issue. It's an issue in everything we deal with, our personal lives, mental health issues, or any other issues that we're dealing with. But what I also heard that we need to do something with our processes, because if 6% of these cases are getting to the probate judge, that's a bad number. And we must measure what matters. We don't know how good or how bad we are at it compared to Chattanooga, Tennessee, or Reno, Nevada. And trust me, those places probably have it even worse than we do. But we don't know. We don't know if we're good, bad, average, miserable. But I suspect we're not very good at it because we don't spend time talking about the processes which will free up funding. So if we've got a pink slip process that is broken, then what are we going to do about it? Talk about it? Well, I think we really have to act. So the way to act is not by functioning as an island. It is by involving all of the experts in this room who have been touched by mental health issues, personally or professionally, or both. But we can't allow a pink slip process not to work, and we know it's broken. We can't allow a jail system to be broken and not to do something about it. We can't allow not having a crisis care facility. And what did we do? I talked with our chief, Matt Brown, this afternoon. Now, the new thing is something that's old. Now we're going to have a mental health facility in Montgomery County. Well, what's old is new and what old is older, right? So now we're getting a crisis care facility to come into Montgomery County. So we've got to really measure what matters. And if we're dropping the ball on things, be accountable for it. RI National, I'm not going to bash them either per se, but that was a bad model before we even started. And a lot of money went into that. And we suffered as a result, and we're further behind in the process. One way to avoid that is not function as an island, but say, we are here to work together to solve this issue. We created flight, don't forget, right? I didn't, but I'll take credit for it. But we did that in Dayton, Ohio, so we can figure out what to do with mental health. And if we have to borrow or steal from other communities out across the country who are actually doing it the way it's supposed to be done, then I think we ought to grab a few members of this group, figure out how to get out to Reno, Nevada, or wherever it is that the experts are actually doing it, and figure out a solution that will come back and fit Montgomery County. Thank you.
Let me see if there's. Let me say, dual purpose, being met with great. Oh, Phil, I saw you go mute and then unmute.
Oh, I'm good. I'm good.
Okay, got it. Inpatient BH unit is truly an acute crisis treatment. Support them, need residential and state beds. We talked about that. See if I say anything on here. Absolute, but police officer, PT, pink slip. We talked about pink slip. There's another comment in regards to pink slip. And I think that's all.
Before Scott wraps up, super quick, thank you. We'll do this again tomorrow at 1 o'clock at the Business Solutions Center on Cincinnati Street by Love's Truck Stop. And then we will do it again Thursday morning at 9 at the Job Opportunities Center on West 3rd Street out by the VA. All of these sessions will be recorded on Zoom and put on the Adamus YouTube channel. So you can go back and look at that again. The chat comments will be there as well. So everybody has access to see what's happening in this room, even if they can't attend one of the sessions, they can see the sessions. So, okay, Scott, wrap up.
Well, I learned a long time. My dad said start on time and end on time, and end early if you can. But I certainly, I do have compassion for those of you, especially those of you that this has impacted personally. So thank you for sharing your stories and being honorable. I agree with you, Wayne, as well, too. I think I've seen this city make significant strides in the opioid epidemic. I mean, massive strides. What I love about this region is the fact that we are nimble, we are quick, and I think we're the most compassionate community that I've ever seen. I've traveled a lot in regards to this country.
I believe if we put all things aside and we serve a purpose to serve the lonely, tired, broken, and afraid, we can make a difference in this community. So what we'll do is we're collecting this feedback. I think specifically what we heard a lot about was what was important is the importance of a mobile response unit and also the importance of crisis center. Some of you even brought up the fact that those services are being actually deployed today inside of some organizations. Did I hear that correctly? Some- Got it. Okay. Fair. There aren't other organizations that are doing crisis center work today? No.
No.
Not at all?
No.
None. Perfect. Okay. Well, then thank you for clarifying that. Thanks, Scott. Okay. But we can say it's limited, fair.
Yes.
Very. limited. Would everyone agree that's important?
Yes.
Fair. Anything else before we go?
I got one question.
Yes.
I just want to know, Phil Plummer stated about the money for this and the jail. Oh, I'm sorry. Phil, I'm Michelle again. So I'm concerned about the piece for the jail. I know that we need it, but are we overdoing the amount of beds that we need? And can some of those beds be used in a crisis center for those who need long-term care? And that is the only questions I like to put before the experts. Thank you.
And then Tina, could I count on maybe someone to answer that later? Is that fair?
Yeah.
Okay, is that fair? Okay. Anything else?
I wanted to make a quick comment about prevention. Sorry, I tried everyone. I don't want to make everyone uncomfortable. I feel like if there was more prevention, so I ran the numbers, and in 2022, it was 14.1 per 100,000 people committed suicide. So in Montgomery County is at about 534,000 right now. So that's about 80 suicide deaths per year. And I was thinking about the prevention piece of it. And I don't know about you, but when I was in school, they awkwardly taught me about sex ed, and then that was pretty much it, other than arithmetic, literature, and math, and everything else. We didn't talk about openly suicide. My parents are boomers. You know, we don't talk about our feelings. That's not something we did. And now that I work with children and I've worked the crisis hotline at Children's and I've spoken to suicidal 6-year-olds, you know, I feel like there needs to be so much prevention to normalize mental health issues, especially the largest population of people killing themselves are non-Hispanic white males. That's just here in Montgomery County. It's different elsewhere. But, and that doesn't mean that there aren't other impacted populations. Black, specifically males, is on the rise, highest percentage. And when you said about counting numbers, we don't know how many suicide attempts that there have been. You know, this is just successful suicides. And I feel like with a great prevention program where we normalize talking about our feelings and getting help and getting therapy and knowing what red flags are, that there would be so much healing from that in every capacity for veterans, for, you know, higher risk populations such as law enforcement and stuff like that. I mean, it's really, really important, you know, and it spans every race, every gender, every age needs that piece of prevention and to normalize saying that things are okay. And I don't know how Adamus can be a part of that, but I would love to see that in the community more, people knowing, you know, that it's okay and what their resources are.
Yeah.
We actually have that in our county. We've got Montgomery County Prevention Coalition, which is actually under the umbrella of Kansas. They do that prevention part, especially with youth. That's what they focus on. And then Jay here runs the center at the VA specified towards veteran suicide and prevention. It's just people, they need to know about it.
Yeah, we did.
Yeah.
That was the problem. Yeah.
There's a lot of people doing a lot of great work. The problem is, it looks like a spider web. And it should look like a PVC pipe. So how do we do that in a more beautiful and compelling way and effective way? So
Just one pipe, not 7 pipes.
fair, yes.
We're getting to be about time, and we'll stay after if we need to.
I'll just make this comment short. I understand everything that's been said. And I think in everyone's capacity as a professional or non-professional, that we all agree that the system is broken. So our challenge is, how do we fix it? How do we do out of the box thinking and take best practices from everyone's different area and start with that? That is something we can do immediately while we're collecting data. Obviously, data drives money, grants, etc. But this is also a bigger picture that needs to be solved, but people are in crisis today. They're in crisis tomorrow. They're in crisis in this hour. So there are quick fixes that we can do, but taking best practices, I think, is a good start because the systems are already in place. We just need to probably change the processes.
I can give everybody my card if they want to send me more later, but let's try it.
Well, hey, thank you for being here. Thank you for participating. Also, thank you for your passion for this, but also thank you for treating everybody with dignity and respect. It means a lot. It means a lot to people. So with that, we will conclude and have a great evening. Wow. Yeah. Oh, yeah, right. See if I can go here. Let's see. I got.